Hello and welcome to Leicester Spot Diagnosis, the page that uses social media to enhance peer-led medical education, because someone needs to be innovative and make use of what otherwise would be a fantastic waste of time. So let's carry on. We're going to go for the rheumatology folder, and I'm going to take you through the next few cases on these rapid fire answers. Okay, this patient is being investigated for ankylosing spondylitis. What is this test called? This is Schober's test. Basically, the level of the iliac crest is determined. It's the supercrystal plane, and a mark 10 centimeters above this and 5 centimeters below this is marked, and the patient flexes their spine, and the distance between the furthest 2 points should increase by 5 centimeters or greater. If it doesn't, this suggests ankylosing spondylitis. Okay, this is Schober's test. Next case. This woman complained of fatigue, pains in her fingers and knees and morning stiffness. Diagnosis. Well, this is SLE, systemic lupus erythematosus. Notice that the malar rash, it's a butterfly rash because of its distribution over the cheeks, over the bridge of the nose, but spares the nasolabial folds. Okay, what is the most useful test to confirm your diagnosis? Well, that would be anti-double-stranded DNA. Anti-nuclear antibody, ANA. Well, most people are positive for this anyway, even without disease, so that's a useful test if it comes back negative, but the most useful test is anti-double-stranded DNA, as it is most useful if it's positive. Next case. This is a 45-year-old patient who has been unwell for the last couple of months. Cold, sinusitis, epistaxis on a couple of occasions. What deformity is seen? Now, this is saddle nose deformity. It should be straight, it's dipped in. Saddle nose deformity. And what is the likely diagnosis? Well, given the history, this will be Wenger's granulomatosis. Saddle nose may also be seen in syphilis or relapsing polychondritis. Does this condition affect small, medium, or large size vessels? Well, it's the vasculitis of the small to medium vessels. And the classic triad of what it affects is the upper airways, so the nose and the sinuses. So upper airways, lungs, kidneys. Upper airways, lungs, kidneys. That's a triad of Wenger's granulomatosis. Next case. What are these skin lesions called? Well, these are Grotterens papules, seen in dermatomyositis. If you see these are actually strongly indicative of underlying malignancy. So if you see these, do investigate your patient for underlying malignancy. Next case. What are these called? These lesions in the helix of the ear. These are called gouty tophi. High serum levels of urate cause these, and these are seen in gout. You may also see them on the phalanges as well. Okay, next case. 50-year-old male with chronic kidney disease, BMI of 30, drinks lots of alcohol, presents with a painful first metatarsal phalangeal joint. What is the diagnosis? Well, given the history and his risk factors for gout, this is almost certainly gout. How would you treat an attack? Well, first of all, you would exclude septic arthritis, because it would be very embarrassing if you missed septic arthritis. And then you would treat with non-steroidal anti-inflammatory drugs. You would not treat with allopurinol. That's for prophylaxis, not for the treatment of an acute attack. And what medications may you want to stop for a while? You may want to stop their diuretics, because this can make gout worse. Colchicine can also be given in an acute attack, although that may cause some considerable GI upset. Okay, well, that's all for now. Okay, if you've come across us for the first time, find us on Facebook. We are Leicester Spot Diagnosis. Thanks for watching.